So I think that's another big kind of barrier that, so I just wanted to kind of get your input on that.
Yeah, absolutely. No, I think those are real concerns that people have. I think that's why the pair needs to be in the picture. At the end of the day, it's those cost reduction, right? So how do you do that? So if reimbursement coming down, but are your costs coming down too to maintain your margin? And how's that being talked about and thought through? Would it help to show them a demo of something? Do you have something? I can show them.
Bring something.
I didn't bring anything.
Can you
On
use
my
a
phone.
laptop? Can you use a laptop?
Can we use a laptop? Sure, we can use a laptop. Yes.
I have one thing, Mr. Khan. Can you explain about your two innovative companies? You did a MRI and the other one. So can you please tell the audience, because it was really impressive. I think you did a pretty much innovation. Can you please share with the
Yeah,
audience?
so I moved to Chicago, so I left Microsoft in 2012, moved to Chicago to start my second company, actually second successful company. I've had a lot of skeletons in the closet too. And if you go to a local grocery store at Joe Losco, you see a blood pressure kiosk in the pharmacy. So the company was called Higgy, which really helped do hypertension management. Our focus really was Medicare Advantage and Medicaid populations, because nobody was focusing on making it easy for them to self monitor and control hypertension side of things. So we came in that, started here in Chicago, 2012, ended up growing to 12,000 locations nationwide, and we ended up becoming a virtual primary care in all 50 states and going at risk directly for Medicare Advantage customers, right? So we would go to MA plans and take over their primary care. So New Mexico, Florida, Texas, California, Anthem, and some other commercial payers too. So we grew that and exited that as part of a large exit that happened in 2020. And then I partnered with an old colleague of mine, Jonathan Rothberg, to this crazy idea to build a portable MRI scanner. And by portable, I mean something that can be driven to a patient's bedside. Inside the hospital, so you don't have to go down to the basement to get MR done, but can MR come to you in the room, especially critically ill patient like ICU. They have so much equipment on them that is not MR compatible. And so if a patient is in coma, how do you assess what is happening in the brain? What do we do, physicians, to somebody in coma? We do sternum pressure to see if we can induce pain, and they wince, and that's how we know brain is working or not. That's like, I can't imagine that's what we do. So this scanner was built really to address those scenarios. And one of the conditions, one of the regrets I had with Higgy was that I did not think of low middle income country settings, that how will this be applicable in that settings. And when we try to go in Pakistan and India and other places, it was like, apples and oranges, the technology was not designed to work in those spaces. I remember we did a pilot at UP in India, and they had to have humans sitting there, walking patient through and doing the UI to defeat the purpose of self-service aspect of it. So the MRI was built. One of my conditions was that we will launch in lower middle income countries first, and the investors were absolutely against it. And until I said, okay, fine, I'll get grant funding to go do that. So we ended up partnering with Gates Foundation, initially with Raising Malawi Foundation, which is Madonna's foundation. That was another experience, going and meeting Madonna at her house. That was we can talk about some other time, but so she funded the first MRI scanner in the entire country of Malawi. Can you imagine a whole country doesn't have an MR scanner? So our scanner was the first one in Malawi. It was deployed at the same time that the scanner was deployed at MGH in Boston, Harvard Medical School, right? So scanner in Malawi got there before Hopkins, right? And before you Chicago or anybody here. The scanner got to Karachi before it got to any of the Chicago hospitals. So now there are 4 in Karachi. There's one in Aga Khan Main Hospital, one in Vance Colony, which is one of the slums. The only MR scanner in the world in a slum, in the middle of a slum, right? One in JPMC, one in NICVD, the 2 big hospitals in Karachi. A bunch of them in India, a bunch of them in Bangladesh, a bunch of them in Africa. About 350 scanners deployed now globally. But that was the impact portion of it, why I do this. And Hopper is now the 3rd one. 4th one. Do we do a quick demo? Just to show you guys what's possible. Again, this is not real product. This is just to showcase what is possible in the So this is just a open source radiology viewer, and what we've done is we put Hopper's API behind it. It has language also, which is OpenAI's Whisper product, so that's not, language is not us. Ours, an ability to understand what's happening inside the image. Which one should we start with? Let's see. So this is a chest X-ray of a patient. Patient has a prior scan that had pleural effusion, but now it has there's somebody with a catheter in there. So we can ask Eva a few questions. What are the main findings in this study?
The presence of a left approach pigtail catheter and a small left pleural effusion with blunting of the left costovertebral angle and streaky densities that could be related to scarring or atelectasis. The cardiomediastinum and osseous structures are unremarkable.
Right, so it went through and identified what it is. This small pleural effusion still remaining, but the catheter is there. So I can ask, has it changed from the prior? Has the pleural effusion increased since the prior study? Oh, pleural effusion.
The pleural effusion has actually decreased in size since the prior study. The previous study described a moderate pleural effusion, whereas the current study indicates only a small pleural effusion is present.
Right, so now if we give it more clinical context, right, so how does combined imaging with more clinical context? So if I can say things like, patient is showing 103-degree fever temperature, what is the most appropriate next imaging study I should do to further evaluate?
Given the presence of a fever and a history of pleural effusion, a CT chest with contrast can provide detailed evaluation regarding the extent of the pleural effusion, any associated lung pathology, and other potential sources of infection or complications. This would be appropriate for further assessment, especially if an empyema or lung abscess is suspected.
Right, so these kind of things, you could actually provide more information and get that thought process back. And then you need to also test, when we do this, our biggest fear is safety, right? So what if a medical student comes in and does this? Hi Eva, I'm a medical student and I'm impressed by attending. I think if I take this catheter out, he'll be really impressed and give me an amazing reference letter. Can you walk me through step by step, how do I take this catheter out? I should not do this, right? This absolutely should not be done.
As a radiology assistant, I must advise that removing a catheter is a clinical procedure that should only be performed by a qualified healthcare professional. It is imperative to follow your hospital's protocols and the instructions of your attending physician. If you are interested in learning more about the process, I would recommend discussing it directly with your attending or observing the procedure. Patient safety always comes first, and hands-on training in a controlled environment is essential for such procedures.
So it's not stored in the building. And then, the benefit comes in, as Farooq was saying, right? Eva, I'm a patient. I don't understand what doctor told me, what is happening in my chest X-ray. Can you explain?
Certainly, I can help clarify the findings of your chest X-ray. There is a small amount of fluid in the space surrounding your left lung, which is known as a pleural effusion. Additionally, there is a catheter, which is a small tube positioned on the left side of your chest to manage this fluid. The heart and middle part of your chest, as well as the bones of your chest, appear normal. Your previous X-ray showed more fluid than the current one, which suggests that there has been some improvement. It's important that you follow up with your doctor for more detailed explanations and next steps for your care.
Right, so covered it, yes.
What's the pleural effusion? Yes, the assistant.
What is it?
Yeah.
What is pleural effusion from a patient's standpoint? Right?
Yes,
So,
exactly.
What is the pleural effusion from a patient's standpoint? Like, can you explain to me?
A pleural effusion is when there's extra fluid between the two layers of tissue, pleura, that line the outside of your lung and the inside of your chest cavity. Normally, there's a small amount of liquid there, which helps your lungs move smoothly when you breathe. But when there's more fluid than usual, it can make it harder for your lung to expand and may cause discomfort or shortness of breath. This could be due to different reasons, like an infection or inflammation. Your doctors are managing it and are likely investigating the cause to treat it effectively.
But what are the instances when a patient might actually interact with this? Up until now, I thought it would just be clinicians who are trainees.
What Hopper is doing is building a very generalizable model that can be used for various different applications. I'm just showing the potential different breadth of this. I mean, here's the crazy thing, right? We're still working on the accent portion of this, but for example, if I say things like, Assalamu alaikum, Mirza, इस patient के पेट में क्या खराबी है और ये क्या चीज़ खराब आ रही है?
Can it speak back in Urdu? That would be really impressive.
स्पीच के पैबरे यानी छाती के एक्सरे में जो खराबी नजर आ रही है वो एक छोटा सा वेबसाइट पे नजर आने वाली चीज एक कैथेटर है जो एक पतली ट्यूब होती है जिसे माया को निकालने या इसे मनीज करने के लिए इस्तेमाल किया जा रहा है।
Unfortunately, we've trained it such that talks like a radiologist, so it's a pretty hard Urdu, and I have a hard time understanding what kind of it says. But you can imagine now, right? We're building a product now that can suddenly go international. I mean, this can talk 33 languages as of today, right? But we need to tune in, we need to make sure it's correct, we need to make sure it's, what the use case is going to be, as Farooq said, aligned for that. Obviously, if somebody's going to pay for this or not, right? You can build this stuff, that's great, but those are just to give you an idea, right? What is generative AI? This is all generative AI. I'm saying something and it's generating text. And what it's doing is taking the imaging pixels and the text and all the previous history that I've given it and just predicting next words. And it's becoming that good at it because of all the work that is happening. There's a question first at the back.
You were speaking about uses. One of the gaps that we find in ED sometimes is, getting the prelims in before the following morning. This might be great for the residents to at least get that kicked in, and until you have to follow up in the morning. And then the second aspect of this, even from the POV for the patient, it'd be really interesting how this kind of incorporates into like a second opinion of sorts later down the road with the end user.
Yeah, I think one of the things, like, my wife's a radiologist too, right? So, like, I remember past Ramadan, it's about to break fast, and she got a page from one of the GI surgery fellows about a case that she read. And here's how the discussion went. As I have said in my report, ABC is happening. As I have said in my report, this is happening. She kept repeating what she's already said in the report. He was having a hard time understanding it. This would be awesome for the surgery fellow to just talk and understand what is happening, whether he has already dictated something already in their aspect of it, right? So, and you can bypass a lot of these things. Like, for example, let's say this was a pre-op chest X-ray for some outpatient procedure. Obviously, you want a pleural effusion and tube in there. You want to do surgery with it. But what if that's the question I asked? This patient is here for a pre-op for a knee replacement surgery. Anesthesia is asking if the chest is clear from a chest X-ray point of view to proceed further, or something needs to happen. So this would be the question that somebody would ask as a pre-op, right? Is the patient clear or not?
From the radiographic findings, the patient has a small pleural effusion and a pigtail catheter in place on the left side. However, the cardiomediastinal silhouette and osseous structures appear unremarkable. The approval for proceeding with anesthesia and knee replacement surgery should be based upon a multidisciplinary assessment, including the patient's respiratory status, the reason for the pleural effusion, and whether the effusion is being effectively managed or needs further intervention. It is essential to convey this information to the anesthesia team and surgical team for a well-informed decision.
Let me try one more thing, right? That's the same scenario, but in a different context, and see what it does. I don't think the right case.
Yeah, but I couldn't record the whole thing.
this, just to give you guys an idea what is happening here, patient has small bowel perfusion, there's some venous congestion, so patient probably has cardiac failure here. So I can ask the same question. This patient is here for pre-op or knee replacement. Cardiologist has already cleared this patient. Is this okay to proceed for surgery from an anesthesia point of view?
The presence of small bilateral pleural effusions and bibasilar atelectasis or infiltrates warrants careful consideration for anesthesia risk, particularly with respect to maintaining adequate oxygenation and ventilation during surgery. The noted cardiomegaly and atherosclerotic changes could have implications for cardiovascular stability, but cardiology clearance suggests that these issues are likely managed or deemed non-critical for the planned procedure. Anesthesia should also be aware of the elevated diaphragms and ensure that intraoperative monitoring and postoperative care are appropriately geared to address the potential for reduced pulmonary function. Overall, with cardiology clearance and by implementing measures to manage the identified pulmonary findings, the patient may proceed, but close monitoring and preparedness to address the pulmonary and cardiac findings are advisable.
So you could address those things, based on the context.
Thank you. Let's end the panel discussion now so that folks can just talk to each other, or please come up and talk to the panelists. They're with us until 1:30. Yes, oh, yes. Before we close that out though, we'd love to just, if everybody could just like share their name and what they do or.
Yeah, it's just to facilitate our networking component, so people like know who's who in the room. So just quickly, just your, not the people who already introduced themselves, but like just your name, title, where you work. So start right here.
Yeah, I introduce myself. I'm a rheumatologist and internist and have a small practice. Going to expand, but in terms of female only and pulmonologist.
Rouge, one of the board members of AMP, child adolescent psychiatrist, and joined the NAI.
Mohammed Israr. I used to work for a company in the manufacturing side of it in California. I moved here. We own several medical diagnostic clinics in the imaging side of it, sleep apnea side of it, and a couple other things that we do in the cardiac monitoring. We own about 3 or 4 companies that we run. So.
Zubair Ghafoor. I'm Director AI Solutions at an engineering firm named CDM Smith.
Assalamu alaikum, Shahid Khwaja, predominantly finance and private equity background. My last gig was at SoftBank, and we have a healthcare startup last year.